I'm Dr. Nilanjan. I'm the consultant cardiac surgeon of this hospital, Narayana Superspeciality Hospital. Today I've got one of my senior, the consultant cardiac surgeon, Dr. Debasis, along with me. So we'll be talking few points, particularly over the adult cardiac surgery. So my first question is, what is the present status of the adult cardiac surgery nowadays? And I mean to say, what are the common conditions where an adult patient will come to you asking for a cardiac surgery?
Thanks, Nilanjan, for that question. I think when do adults require cardiac surgery? I think most of these conditions are acquired conditions. So the commonest being coronary artery disease. So we all know that coronary artery disease is a condition where there is insufficient blood flow to the heart because of these arteries getting clogged by various things, cholesterol being one of them, but there can be multifactorial. So coronary artery disease is one of the major chunk of adult cardiac disease. Second is degenerative and rheumatic valve disease. So these are all acquired diseases which manifest in adulthood, where the valves in the heart either start leaking or they get obstructed and not enough blood flows through them. And in addition to this, there are certain conditions of childhood which are diagnosed very late in adult, which comprises a very small population called adult congenital heart disease. And some of the patients fall in the category of advanced heart failure, which is a separate category where structurally the heart is normal, but there is not enough pumping ability of the heart. So these are the main broad categories of adult disease, coronary artery disease being the commonest.
And so there's a lot of excitement in the market that probably every patient can be stented or they can undergo any kind of a stent placement to relieve whatever the pathologies they are harboring. Is it true? I mean, is every patient can be put under the stents?
So yes and no. I think what has happened over the years is, as we know, any new technology when it comes, there is a lot of hype around it. Stenting for coronary artery disease has been there for a very long time. It is an established way of treating coronary artery disease. However, there are only certain variety of coronary artery disease which can be treated with stents, and that has. So whether you treat coronary artery disease by a stent or surgery is not actually a competitive technology. It's a complementary technology to each other. There is a subset of patients of coronary artery disease which is like a diabetic population, advanced triple vessel disease. Those patients are better treated with surgery rather than stents, because in the longer run, all the studies have shown that those patients do better. However, if the patient has a single vessel disease, a double vessel disease, or a multi-vessel disease with multiple comorbidities where we think that surgery becomes too risky, those patients can probably be stented. So I think these are all complementary technologies where I think these days the concept is having a heart team where once the patient has been diagnosed, the cardiologist, surgeon, the physicians, everybody gets together and decides as to this particular patient what is the best therapy, whether it is stent, whether it is surgery. And certain diseases will fare well with surgery, certain diseases can be tackled with stent, but no, stent is not the universal answer for all coronary artery disease.
But do you think that the indications or the horizon of stents have really increased?
Yes, they have. I mean, say 10 to 15 years ago, stenting in multivessel disease was probably not as common. Then stenting in left main, which is one of the main arteries supplying the left side of the heart, was not common. But these are certain areas which have opened up to stent these days. They're all under various sort of studies to evaluate as to, in the longer run, whether they stand up to the gold standard of surgery. If it does, then well and good, because obviously the patient is avoiding a major surgery. But if it fails to provide the same sort of long-term outcome, I think that is something which is under investigation in various trials, and we'll come to know in future what is happening. But yes, the scope of stents has definitely increased, and which is not a bad thing, which is actually a good thing. If something is more safe for the patient in the current era, why not?
So what are the common substrates of coronary artery patients you are doing now?
So most common subset that we do these days are definitely advanced, poorly controlled diabetics with multivessel disease, having already suffered 1 or 2 heart attacks, probably having already undergone 1 or 2 stents. So the patients are a lot more sicker. They have already probably had some bad effect of coronary artery disease already in terms of having a heart attack previously, having one intervention or even multiple interventions beforehand. So the patients are a lot more sicker, they are a lot more elderly these days, as well as they come after a primary intervention in terms of having a stent before and then undergoing a surgery. That is what has changed in last sort of 5 years. Once the number of stents has increased, that is what will happen to surgery.
My last questions in coronary artery surgery is the surgical innovations which now people are talking about is a total arterial revascularization. So where do you stand on that?
So basically, as I said, the whole premise of coronary artery surgery is based on long-term outcomes. So it has been shown in studies that if you put more arterial grafts, they last longer. However, that also has to be balanced vis-a-vis the particular patients. As to, it is not a universal therapy for all. If there is a 75-year-old person with very bad advanced coronary artery disease, putting multiple arterial grafts is probably not the solution. At the same time, if there is a person in sort of mid-40s who comes with, and you give him 3 arterial grafts, he is probably the candidate who should benefit more. Mainly, what are we aiming at? We are aiming at keeping those graft patients for a very long time, minimum of around 10 to 15 years without any problem. That is where the role of total arterial revascularization comes. So it is definitely relevant in younger patients who do not carry any additional risk factors for total arterial revascularization. But at the same time, all coronary artery bypass grafts should at least have one arterial graft to the most important artery, which is called the LAD. That is what determines the main long-term outcome of the patients.
So my next few questions will be centered on the valvular heart disease. So is it true that the rheumatic heart disease are now gradually decreasing in our country and you are getting less number of rheumatic patients to operate on?
To an extent, yes, but not to the extent that we would actually want it to be. So rheumatic heart disease as an incidence, because it is related to the economic health of the country, to the standard of living, because it is a sequel of what happens in childhood. Because of streptococcal throat infection is the genesis of rheumatic heart disease, and that has decreased. So we do see rheumatic heart disease even these days, but probably not as common as it was sort of when we were training around 10-15 years ago. It has decreased, but it is still there. A lot of degenerative valve disease these days comes, which is probably, which was a minority of valve disease, that is probably half and half. So half of the valve diseases are still rheumatic and half is degenerative. Previously, it was the other way around. Rheumatic was the predominant population. That has decreased over a period of time. But it has not disappeared, and I think even for the near foreseeable future, it is going to stay for some time.
As we know, there are two kind of the artificial valves. The one is the mechanical and another is the biological valve. So how often you are putting the biological valves?
So the two different valves that we have is mechanical and biological based on what substance these are made up of. Biological valves are derived of animal tissues, and the advantage of biological valves is you probably do not have to give blood thinning medication, which is the anticoagulation, for a very long time in these patients. But they have a separate indication. In a young patient, so the disadvantage of biological valves is they don't last as long. So in an elderly patient, or say 65 years and above, if the patient requires a valve, so our main therapy of valves will still be an attempt to repair the valve. If it is not repairable and we are supposed to put an artificial valve, in 65 years and above, definitely we put a biological valve so that all these anticoagulation, blood thinning medications are avoided, making it safer. Whereas in a younger patient, our aim is to have a prosthesis which will last lifetime, because in this country, still having a second operation is a major thing. So we would more or less put mechanical valves in less than 65 years of age. However, certain patients who would actually opt for a biological valve, they are aware of it, they don't mind having a second surgery and would want to avoid the blood thinning medications because of their lifestyle. In that, we will respect that choice and put it even in a younger age group, knowing that this patient might require a second operation at some point of time.
So we are almost at the concluding part of the session. My last question is around regarding heart transplantations, because we have seen in the couple of years there has been quite a number of heart transplantation in various the hospitals across the city. So what are the common situations or the common cardiac pathologies which may require a heart transplantation?
So basically, heart transplant is a therapy for advanced heart failure. It is true that heart transplant has picked up in India in the last few years, and most of the cities have facilities for doing that. Advanced heart failure is a condition where the heart is not pumping enough blood and has become very weak. And there are various modalities of treatment. So you first treat it with medicines. Then if there is some sort of a rhythm which is leading to this, there are advanced pacemakers which can improve your pumping action. And After that comes, there are certain devices like assist devices which can help you sort of regain the pumping action of the heart. Only a minority of advanced heart failure who are not amenable to any medical therapy or have been on medical therapy for long and are not improving and in fact deteriorating over a period of time, those patients will actually require a replacement of the organ by another organ, which is heart transplant. So it is a therapy which is required in advanced heart failure in a minority of patients. But those patients who require do not have any other option. And heart transplant is a safe procedure these days with a very good long-term outcome if followed up properly. And that is an option we cannot afford to ignore anymore. That is a therapy which has to be there in our armamentarium. If we are treating advanced heart failure, we cannot take heart transplantation away from the patient's choice. So we have to have that in our armamentarium.
Can anybody donate the heart? What is an ideal donor?
So there is mainly it's an age. So I think above 65 years of age or maybe even 60 is a non-optimal donor. These days, the donor criteria has been sort of diluted significantly to expand the donor base. But elderly person is probably not an ideal donor, as well as a patient having sort of a active infection or some sort of a communicable diseases which the recipient has the chances of communicating. That is not there. Other donors whose other organs are well functioning, the heart is in a well preserved state, doesn't have coronary artery disease, hasn't suffered any heart attack, and unfortunately lands up in a situation where the patient is brain dead, is a donor. So I think these days main is absence of any communicable diseases, mainly viral infections like hepatitis C and an advanced age. These are the two people who cannot sort of who are non-optimal donors. Otherwise, everybody is a potential donor. And again, organ donation is an awareness issue. So I think if more people are aware, more organs will be available, and this therapy can be available to many more patients than what it currently is.
Is it important for the blood group of the donor and recipient to match?
Yes, for heart transplant, definitely the blood group has to match. For other organs, solid organs like kidney, there are even advanced tests which have to match. So for blood, mainly for heart transplant, blood group has to match currently. Although it is in infancy where there are non-compatible blood group transplants, which is already a therapy in kidney. In heart transplants in India, I don't think it is still a standard therapy to transplant an organ which is non-blood group matched. But with immunosuppression, with advanced plasmapheresis, advanced techniques, you can actually transplant an organ which is not matched to a blood group also. But that is a matter of research currently, not a standard therapy.
For any transplantation, there is a point of rejection. I mean, rejection can happen anytime. So is there any bad recipient, who are more likely to show the signs of rejection?
So certain individuals will actually have certain things in their blood and in their body which makes them more prone to reject anything. These patients are already allergic to many substances, they're allergic to other things. So you know that these patients will have circulating antibodies in their blood. So there are screening tests by which you know that this is a patient who is prone to develop rejection of most of the stuff. If that patient is the one who is the recipient, you would be extra careful to match almost all criteria before transplanting an organ. And after transplanting, you would keep them on a surveillance for a longer period compared to a normal patient and do the tests more frequently.
My last question before you can conclude on whether these patients require a long-term antibiotic prophylaxis or they need some kind of a vaccination. For example, pneumococcal vaccination.
So they require vaccination, but not long-term antibiotic. Yes, vaccination in terms of pneumococcal vaccines, because they are immunosuppressed, they would require so that they don't. But long-term antibiotics, no, they would require antibiotic for a period after the operation and even after that. But after that, they don't require routine antibiotics. They would require antibiotics before a procedure if they're undergoing any dental procedure or anything. But and they would also require their immunosuppressants for lifelong. But not routine, yes, and certain vaccines, but not routine antibiotics.
Thank you very much, Dr. Das, for enlightening and discussing the very pertinent points.
Thank you.
Anything you want to say in conclusion?
I think as far as adult cardiac disease is concerned, coronary artery disease is the main chunk, and in addition to that, we have valvular heart disease, adult congenital heart disease, as well as advanced heart failure. Coronary artery disease is a lifestyle disease. If we change certain aspects of our life of eating healthy, exercising regularly, keeping a tab on your weight, as well as avoiding to smoke, and having an awareness about family history so that you get an annual checkup regularly, we can pick it up at a stage when it hasn't done damage to your heart and treat it at a better time. So awareness again being the key.
Thank you. Thank you very much.
Thank you.